Hi, thanks for watching again. This is the Doctor Podcast Show, episode number 79, and I'm Dr. Robert Sykert, your host. Thanks for tuning in, and please subscribe and follow Doctor Podcasts, and of course, like and repost this specific episode because I'm sure you'll love it and learn lots of information. Today, we're talking about a very important subject, and that is the subject of blood shortages. There's a blood shortage all the time, especially sometimes around holidays, sometimes when there are calamities, and we have to learn how to utilize blood better. And we have an expert guest about that subject today. We have Sherri Ozawa. And Sherri's a clinical director, an advanced practice nurse, and specialist in patient blood management, or PBM is the abbreviation. She's the founding member and past president for the Advancement of Blood Management in Englewood, New Jersey. And she's also the director of delivery and operations of the blood management company called HC1. Sherri, thanks very much for taking the time to join us on the Doctor Podcast Show and talking about this important subject of blood shortages. Really appreciate you taking the time.
Thank you, Robert, for having me. It's a pleasure to be here. Appreciate it.
Thank you. So tell us how you got interested in nursing, first of all.
Well, of course, like many people, a long story, but I'll keep it short and say that I was actually a musician. I'm a cellist by training and was a music therapy major in school. And wish that the arts provided the living that they should probably. It's a subject for a different podcast. But then
Right.
there's an interest in patient and improving patients' lives, improving the community health, and went back to school for nursing, and have been a nurse now for almost 30 years.
Wow. Interesting. You're still playing cello, though.
Yeah, that's an important piece of your brain, right? That you still have to use. So,
Absolutely. Right. Keeps your brain fine-tuned. So tell us how from nursing you became interested in patient blood management. Tell us what patient blood management is.
sure. So I actually came from northern New Jersey, not too far from where you are, and worked at Englewood Health, which is an academic, community academic institution right outside New York City. And in the mid 90s, the hospital decided to start what is still called a bloodless medicine and surgery program. There's many hospitals around the world who actually have such programs, and the intention of such really was and is to take care of patients for whom blood transfusion is not an option. Maybe patients have religious beliefs, personal conviction. They might have medical reasons that they can't receive transfusion of other people's blood, and really that this patient population had a real challenge finding adequate care for lots of reasons. And then really, particularly during the HIV horrific crisis that we had a real change in viewpoint about blood. And there was a real sort of halt to a lot of transfusion activity. Now, the great news is, right, that we're not here to scare people about HIV and hepatitis. There's great testing. Our colleagues in transfusion medicine and blood banking are very diligent. They are very concerned about patient safety. But it did give us a pause to say, what were we really doing transfusing as much as we were when we couldn't? We still managed to do surgeries. We still managed to deliver babies. We still managed to take care of people, yet reduce our use of blood so much. In addition, now we have a community need, right, where patients are saying we need this type of care and we need to find a place. So I was very proud, continue to be proud of my home organization that started this program in the mid to late 1990s. What we very quickly realized is by taking care safely of patients for whom transfusion was just not an option, we just sort of took that off the table. We were doing a lot of other things to maintain and preserve the patient's own blood, to optimize their care, to make sure they weren't anemic, to have really collegial conversations between surgeons and anesthesiologists, and very quickly said, why would we not do that for everyone? It sounds so almost overly simplistic, but that's actually the way it developed. And that made us say, well, what are we doing with transfusions? Why are we giving them the way we are? How did this piece of our medical practice that's so common even evolve? And that in the late 2000s, the late 1990s and early 2000s led to what we now call patient blood. We didn't have a name for it then, but patient blood management.
Let's see. So, what was wrong with the previous model of doing blood transfusions, and why is that outdated and not sustainable currently?
Yeah, I'll probably spend the next few minutes talking particularly about red cell transfusion. It really applies to all the different components, right? Because we transfuse platelets and plasma and cryoprecipitate too, but most commonly red cells. So we kind of have to follow a path which is both historical and cultural, and unfortunately not all that scientific. And I will give you the long history, but the short version of the fact that blood really entered into our common medical practice in a very atypical way from almost everything else we do, right? So as clinicians and as the public, we feel reassured that anything that goes into or onto a patient has gone through a rigorous process, right? We have a federal agency that helps do that in the United States, and certainly other countries, developed nations, and even developing nations have the equivalent of our FDA. And so as we know, drugs, for example, have to go through an extremely long and torturous process to be released to the public, whether over the counter or by prescription. We would imagine that something like blood, which, and we can talk more about this in a minute, but really is actually a liquid organ transplant, right?
Right.
Although it's maybe used more like a medicine, sometimes like an IV fluid, it really is a liquid organ transplant. It would have gone through some incredible rigorous testing to prove essentially that it's both safe and effective. But the reality is that never happened. So if we look at the history of transfusion practice, it entered into our medical world during the World Wars as we learned how to store blood, we learned about blood typing and all those things, which were tremendous scientific advances and allowed the transfusion of blood components, which again, clinically may be indicated for some patients, but we never really tested blood transfusions to establish safety and efficacy. So they really became something that were much more based on habit and culture. And we really want to believe that everything we do in our practice, right, is based on solid evidence and data. Unfortunately, when we started to look at this in the early 2000s, we found an entire chapter of science entirely missing around the world from everyone. And we just transfuse because it must save lives. And then we had our media sort of reinforcing that, right? We're clinicians, right, but we're also members of the public, right? You watch any television show that's medical. We don't even know what's happening to the patient yet. They're calling for, 4 units of O negative to hang, and there's a visual aspect. And blood represents a lot of things, right? Culturally, religiously, and symbolically. So those actually have all entered into our schematic mentally and led to this tremendously non-evidence-based practice where we did it. We may change a number on a lab result, but do we really have the evidence that we're actually helping a patient by improving the outcome? The way we would rigorously say, if I give this patient this antihypertensive medication, I know the likelihood is this is what's going to happen. I know the statistics around it. I know the safety. I know the side effects. With blood, we just do it because we've always done it.
So you mentioned the red blood cells. That's the part of the blood that carries the oxygen, which you need. And the typical blood tests we use to check for that are the hemoglobin or the hematocrit. Those are the standard blood tests. My impression was, and maybe I'm wrong, and maybe I've just been taught that without really looking for the evidence, is that if somebody's hemoglobin drops below 8 or so, they're in danger of not getting sufficient oxygen to their brain and heart and kidneys and other organs. And that's kind of the point where the doctors order the blood transfusion. So are you saying that's not a reliable way to determine when to give somebody a blood transfusion?
Yeah, no, that's a very, very smart question and a logical one. It's one that's in the minds of many clinicians because clinicians want to do the right thing for patients, right? We want to improve the outcomes. That's why we went into this business. And the reality is that if we really, again, think of blood as the body's liquid organ, the way that it both picks up and delivers oxygen is much more complex than vision we probably all learned even in middle school, right? And then on through medical or nursing school. So that's a complex interplay at the cellular level with between those cells, the endothelium, and those tissues. And again, not to go off in a big discussion on physiology, nobody knows exactly what that number is for every individual patient. So the
Right.
point is, just like with any other significant invasive intervention, like an organ transplant, again, I don't want to keep coming back to that, but think of how we approach it, right? When a patient has a problem with let's look at renal failure, let's look at kidney failure, right? We start to see a problem with their numbers. Maybe their BUN and creatinine are off, and we address that, and we do lots of things. We do medical management. We might advise them to change their diet and lifestyle. And we do all these things, right?
Right.
Eventually, maybe they end up on dialysis. As a very last resort, right, the patient may, if they're qualified and if it's available, because it's such a precious resource, we may replace, right, that organ. With blood, we often try to fix a number and we don't actually know what that number is, right? So clearly people can't have zero hemoglobin. They can't have no red blood cells, right? Those
Right.
cells, as you well said, they are responsible to deliver that oxygen to the tissues. But the point really is that we should never make this decision just based on a number, right? We should be looking at the signs and symptoms that the patients are giving us along with that number. That number matters. But
Right.
again, patient blood management is about managing and preserving the patient's own blood. In the simplest sense, keeping the blood in the patient and keeping it healthy. And as a last resort, maybe it needs to be, if it's acceptable to the patient, maybe it needs to be replaced from a clinical indication standpoint. But we should never do that just based on a number, although that's really the way many of our friends and colleagues have learned to practice. And it's not because they're bad guys and gals. It's just that's the habit of our medical institutions. So the point is, there's a hemoglobin threshold that we view as normal from laboratory results. We are concerned, just like if a patient's BUN and creatinine were off, we would say, what's going on? We better take a look. We want to take a look if we see a patient's hemoglobin lower than normal. But we don't immediately jump to transfusion. We try to solve that problem every other way first. And then again, if acceptable and available, then replace the organ. If that makes
Right.
sense.
So is this a reasonable example of what you're saying? Let's say you have a healthy 25-year-old who
Mm-hmm.
unfortunately is in a horrible car accident, loses a lot of blood, and winds up in the emergency room. The hemoglobin's 8, but the patient is not having any symptoms or problems from that necessarily. So you wouldn't want to transfuse that 25-year-old because their bone marrow is going to produce more cells, which will kick in a few days or a few weeks. On the other hand, if you have somebody who's 70 and has been in the same accident and has a history of heart disease and possibly kidney disease, then you might want to transfuse them earlier rather than waiting for them to have symptoms. Is that a reasonable way to assess this?
Yeah, in large part, Robert, I think you've captured a lot of key thoughts in those examples. You've also perhaps captured a couple of misconceptions. So the first I'll say is that, um, in example one, I love the way that you said that about that young person and giving their body time, because again, blood is actually the only organ that will completely regenerate if we give it
Right.
enough time and we give it enough support. At the same time, there are certain factors that we will commonly use and I'm not making any judgment statements, but we will commonly say, well, the person's older, well, it's a woman, well, they might have some history here. Again, where is the evidence base? And certainly there is now evidence, and I think that we have worked very hard. We have a very large global community to encourage our colleagues and friends and fellow academicians and clinicians to produce a lot more science. So now there is a lot of data out there. But there's still not a lot to support that we necessarily transfuse. Elderly people do get transfused, but not necessarily for any good reason, right? Just being elderly, those patients often still have the capacity to regenerate their own liquid organ. So the point being, and I think you said it well, is that every patient is different. So we should
Right.
not just look at that number. We should really look at, how is that patient really tolerating the situation? I'm sure you've seen patients throughout your training and through your career that are walking around with very low hemoglobin levels because they have accommodated that. Some women, for example, and that's a subject we'll get into probably in a minute, but who have heavy menstrual bleeding, let's say for years, they can walk into a hospital and say, I'm a little tired, and the hemoglobin maybe 3 or 4, right? Something we might say that that's not even associated with being alive, yet they're living and working and taking care of a family because they've accommodated. So just like every
Hmm.
other organ system, our blood has this incredible ability to accommodate if we support it. And the key being in that accident scenario is really stopping the bleeding, right? So, like, again, we have sort of that image from ER in our mind, like, oh my God, the patient's bleeding, replace it. I guess it sounds overly so simplistic, but really, like, again, focus on stopping the bleeding. That blood will, for most patients, not everybody, I'm not saying it's a Pollyanna world, but for most patients, if we control the bleeding and we manage that appropriately and we support them, they will make their own blood. So keep the blood in the patient and keep it healthy. That's really what PBM is.
Yeah, stopping the bleeding is key. Are there organizations in the USA, for example, the CDC, and even in the world, the World Health Organization, WHO, that are involved in creating programs to reduce the amount of transfusions that are done and to be more considerate of when to do a transfusion, when it's truly indicated versus when you can wait a little bit?
The short answer is yes. Lots of organizations are taking more of an interest. We're really excited about that. And I think the key to this whole conversation really is the focus on the patient more than the product, right? We've always approached, and again, this is not a critique of all of us and our colleagues, but we've always approached this sort of through the product conversation. How do we get enough product? We have blood shortages. How do we get more donors? How do we encourage people to go, you know, roll up their sleeve? And we're not criticizing any of those efforts. We almost never talk about the demand side, right? The utilization side. And so we're very happy that, again, various organizations at this juncture about 2 years ago, the World Health Organization, and I was very honored to be part of the working group for the WHO Patient Blood Management Initiative. But they put out a policy brief, and I'm not sure how we share content, but there's a link available, or somebody can Google WHO and PBM and see the policy brief on this, where it really, again, doesn't focus on this. PBM is not about just avoiding transfusion. It's about this unbelievable untapped resource of the patient's own blood, which we have just universally sort of ignored. We have almost a third of the world's population walking around iron deficient and anemic, and
Hmm.
disproportionately women and children, right? So there's issues of health equity and disparities that are would last longer than this podcast. So, and we have another 600 million people with bleeding disorders. We sort of have just ignored those and put up with those and said, well, when those people have a problem, how do we get enough blood for them? How do we increase the blood supply? We're never going to, there's always going to be a mismatch in that. And so we're not
Right.
discouraging people from being generous and being altruistic to their communities or to their neighbors. But we as clinicians have the obligation to do something about the demand side, and that's patient blood management, right? It's about the patient's blood health. And that's a term that we've developed and are now publishing. We've talked about heart health, and now we talk about brain health. We talk about even skin health. What about our patient's blood health,
Right.
right?
Nobody
Sort of
talks
ignored it.
about that.
We don't talk
Hmm.
about it. So we want to start that conversation. And the World Health Organization and certainly other societies, though, are having that conversation. And we are now working on actually an implementation guide for low, middle, and higher income countries because, right, the capabilities, the resources are quite different in different parts of the world. But everyone can do something about patient blood management, even if it's just better diagnosis or recognition, or teaching people to use an iron cooking pot so that we help their iron deficiency, to places like here in the United States where we have access to highly technical instrumentation or pharmaceuticals, right? There's whatever you have anywhere in the world, we can do something about that demand side and keeping the patient's blood healthy. So there are organizations working on that.
Now, we mentioned about the risks of your hemoglobin going too low, but there are risks of blood transfusions. So, are we trying to avoid those as well? Because occasionally you can have transfusion reactions, even though you
Sure.
test the blood in advance. So, we'd like to avoid
Sure.
that, obviously.
Sure.
There's also a tiny, tiny risk of getting an infection, although, like you said up front, the blood is very much tested these days, so it's extremely rare to get an infection from blood. But are those the two risk factors?
So I wish they were the only risk factors, and those exist. And to your point, and to our earlier points, right, we have very, very competent colleagues who do a very good job of testing our blood supply. Now, we can never make it perfect, right? There are quite a number of pathogens that the CDC knows are in our blood supply. A good example is Zika virus. We knew Zika virus was in the blood supply for decades. We didn't know what it did. Of course, it turns out it does do something, right? So as
Right.
time goes on, there's more and more testing. So again, it's not a critique of that, but really the greater risks associated with transfusion are not necessarily the infectious ones. They're a couple of things. One is the human error factor, right? Where we're just humans, all of us, and we make mistakes. And blood, from the time it leaves that donor's arm until it goes to the recipient, it passes through many, many hands.
Right.
Now, hospitals have excellent mechanisms, right? As a nurse, well familiar with the processes to try to make this as safe as possible to avoid errors. It's right, you can never avoid errors 100%. So there's the human error factor. But in terms of the actual process physiologically of transfusion for every single patient, 1-to-1 ratio, we have a negative effect on the patient's own immune system. And an interesting way to illustrate that, and we never think of it this way, but you learned it, and I learned it, you learned it in medical school, and I learned it in nursing school in the early days of renal transplantation before they had drugs to manage organ rejection. They
Yeah.
used transfusion because patients who were transfused more rejected their allografts less. Now, maybe that was good for that subset of patients, but at this juncture, do we want to reduce our patients' immune function at all, especially those in the hospital? I mean, that's the
Hmm.
last thing they need. And again, that's not to say that transfusion is never, never indicated, right? For some patients, that may be clinically indicated. But conservative estimates said that our overuse of red cells in this country are 50 to 60%. So 50 to 60% of the time, we had no good reason to give the blood at all. And in the case of platelets and plasma, maybe as high as 90%. We didn't even have an indication to give it. We may have the habit, we may fix a
Right.
number, but we're not actually necessarily helping the patient. So those are actually the more significant, some of the more significant risk factors for the patient. There are huge risk factors um, in a global sense, in an epidemiological sense, in terms of outcomes. And that you may not be, you and I may not be able to see that in a 1-to-1 ratio, right? The patient gets a transfusion, they're that one sad, unlucky person who gets an infection, and this happens. But over large populations, when we look at the impact, and now there are literally thousands of papers that have looked at this over these 20 years we've been working in PBM that say, well, we've been doing this now for decades. We must be making patients' outcomes better. We can't possibly be not helping. But paper after paper after paper from around the world consistently say that in every single patient population we look at, in almost every case, transfusion is either not helpful or leads to poorer outcomes,
Hmm.
longer lengths of stay, more post-op infections, more recurrence of cancer, more cardiac problems. So that's epidemiologic, and maybe not be able to see that on a 1-to-1 ratio, but that data, there's a plethora of that data, yet still we haven't necessarily changed our dialogue. We're still saying, oh my God, how do we get more blood into the system because we must need it, rather than saying, am I really, based on the current evidence, sure that I am, or likely, we're never sure 100%, right? But am I more likely to be bringing benefit to this patient than harm, based on available evidence, not based on my habit, not based on what I saw my attendings do, not
Right.
based on what I saw on TV, based on the literature? Am I likely to improve outcome? And we'll find that in actually probably most of the cases, the answer to that is no.
Hmm. So we need to collect more data and have very strict criteria on when to transfuse rather than just having a general signal. Oh, you've reached 8, we're going to give you a transfusion.
And the thing is, Robert, you're exactly right, but that's there. That information
Yeah.
is there, and yet we largely tolerate people not paying attention. Where with other parts of medicine, to look at antimicrobial stewardship. How did we manage that, right, in the 90s and into 2000? We said to our clinicians, we have a problem with antimicrobial overuse. We have a problem with the
Right.
antibiotic, right, resistance. This is how we're going to do it. Okay, you don't get to order any antibiotic you feel like anytime you feel like it. These are the ones that we're going to use. And maybe some people didn't like it, but very quickly we got a handle on that by saying, here are the parameters. You don't get to go outside those. We are very, very loose with blood because it's blood. And I can't give you I wish I could give you a better scientific reason that this is the reason, but it really is, people react, it really is a very different response to the need for blood. So yes, those, you're exactly right, but that literature is there. There's thousands of articles that tell us and thousands of sets of guidelines that tell us really the true clinical indications. We just don't pay attention to them. And we don't pay attention to the patient's own blood, right? We look at, in the course of my daily work, we look at the prevalence of anemic patients here in this country, where in theory, we have reasonably good access to nutrition. Not everyone, certainly there are disparities, but access to supplements. And it's not uncommon for 40 to 50% of patients who show up for elective surgery, right? So in theory, we had time to plan, we had time to prepare, we had time to operate, for them to show up anemic, iron deficient anemic, particularly women's health. It can be up to 75% of our ladies are showing up either to have a baby or to have some kind of GYN surgery anemic. Many times they've had heavy menstrual bleeding for decades, but nobody asked the question. Or we just said, well, she's a lady.
It's that high, 75%.
Yeah, so, yeah, and in some populations more. And that's true. We look at heart surgery, we look at orthopedic surgery, right? Orthopedic surgery is for the most part elective,
Right.
joint replacement, spinal surgery. I mean, patients may be in pain, that's important, but from a medical standpoint, those are not emergent surgeries for the most part. Many of those patients, the literature is telling us 30 or 40% of them are showing up anemic. We can't control every risk factor, right? We can't make our patients any younger. We can't change the life they've lived, but we can do something about their anemia and oftentimes their bleeding risk by just paying attention, right? And
Right. If you're starting low and then you have surgery and you lose some blood, you're going to be in trouble and then need a transfusion. But if you fix it ahead of time, you wouldn't be there and you wouldn't need the transfusion.
it sounds so overly simplistic, but that truthfully, honestly, in a lot of cases is as easy. Now, there are more complexities, right? And not every patient fits into a simple formula, but really many, many, many of them do. And just again, disproportionately our female patients, we have done a huge
Mm.
disservice to them. And there are huge implications to that, particularly in our pregnant ladies, because now the data is showing that for years, for decades, there's an impact on the fetus, on the baby, on the child, on the adolescent, on the teenager, learning, social development, all these different things from iron deficient moms. And a lot of times these moms, I was one of them, and I work in this business, 4 babies, and I was walking around with a hemoglobin of 7 chewing ice thinking, well, I'm tired, it's normal. I work as a hospital administrator. Of course, I'm tired. Well, and I do it for a living. So we just sort of tolerate.
7.
Yeah, yeah. And so I
Wow.
needed iron, right? But it's so funny, right? It's a story of many, and I get to give this sort of talk to many of my colleagues, nurses and physicians, and I'll ask a room full of first-year residents or even attending surgeons, how many of you yourselves have been diagnosed as anemic or iron deficient? And almost every hand goes up in the room of our female colleagues. And that's us, right? In theory, should know better. What about the public who gets
Yeah.
almost no information on the subject? So
We're,
there's huge implications to this.
we're overlooking preventive medicine in many ways.
We really are. And
And
it's
also chronic disease, we're overlooking that.
exactly.
Yeah.
And then when the patients do, right, come for surgery, and if they bleed, right, there are better ways to manage that, but sometimes we don't do those either. So yeah, come with a patient who's got less money in the bank, and then we're spending it too liberally. We end up in the transfusion question, but we
I
didn't
like
have to, avoidable.
Yeah. I like your antibiotic analogy because back when I was an intern and resident, I could order any antibiotic I wanted on any patient. Nobody
Mm-hmm.
asked. There were no criteria, and basically you ordered whatever you wanted. Over the years now, there are strict criteria. When you order an antibiotic, you have to explain why you're ordering it, why you need that specific antibiotic, why you're not using other antibiotics,
Mm-hmm.
less chance of creating resistant bacteria and other organisms. So
Exactly.
I think it's a great analogy for blood situation.
Right. And to take that analogy just a step further, the one that we like to use in this developing field of PBM is one like infection prevention, right? Like you've been around for a few years, as have I. When when I started as a new baby nurse almost 30 years ago, your patients had infections in the hospital. That was terrible. We felt bad about it. We try to figure out why, but it was not all that organized. And then over the course of time, we developed not just programs that looked at antibiotics, which were the intervention maybe for some patients, but we looked at this much more globally, right? Infection prevention became this combination, this multidisciplinary effort that never went away, which involved hand washing and certainly antimicrobial stewardship. But careful examination of what happens when patients did get infection. Why did it happen? Did it have to do with a break in practice, or so it became its own living sort of specialty inside hospitals. We wouldn't want to go to a hospital that didn't have an infection prevention. I mean, they couldn't exist, right? It never can go away. And so it's a similar approach. So instead of talking all the time about the antibiotic, we made it more global and said, what do we do about all infection? And the patient plays a role too, right? All infection prevention. Now, we would like a patient to say, you didn't wash your hands. Like, patients feel empowered to say that, right? Does a patient feel equally empowered to say, like, what's my blood health like? Right? Did you look at that, or did you just tolerate the fact that I'm anemic because I'm old, or because I'm a lady, or 100 other reasons? Because anemia is not an innocent bystander. Bleeding problems are not innocent bystanders, and there are lots of really undiagnosed even bleeding disorders in our population because we don't necessarily ask the right questions, and then we find out at the wrong time when they've had an accident, they're in surgery. So there's so many of these things that are preventable, but we have to take a more global approach.
I like what you said that blood is a liquid organ and we're kind of ignoring it.
Right, because it's been perceived as readily replaceable. But
Right,
if you just change that little bit of your thinking and say, if I treat it like I treat other organs, replacing it becomes the last choice. You sometimes have to clinically,
right.
but you do all the other stuff first, and then you move to that. With blood, somehow our brains say, oh my goodness, the patient's bleeding or the patient, I got to replace it first and ask questions later. And we actually usually don't even ask the questions because the numbers look better and we got to get that patient out of the hospital or back home or wherever else. And we've temporarily patched a problem, yet increased actually the risk to the patient and not really solved. It's a temporary therapy. It does not, transfusion does not fix an underlying problem.
Right. Now, you mentioned other things, and earlier you mentioned about stopping the bleeding. So currently, or up to now in the hospitals, when you wanted to check why somebody's bleeding, you'd send off some blood tests, get some blood from the patient's arm. You have to send it to the lab. The lab does some testing. It can sometimes take 45 minutes, an hour to get results. I understand there's a newer and better way to do that called ROTEM. Can you
Mhm.
tell us about that and how that works and how it's better than the older procedures and techniques?
So a ROTEM is sort of short for a concept or a scientific approach called rotational thromboelastometry, big word, but to make it very simple,
Yeah, it's a
it,
good thing they have a Rotec. Right?
yeah, exactly. They've found a much catchier name for it, but it allows us as clinicians to really look at the way a clot is forming or not forming, or how it's being dissolved. And there are sort of those traditional tests like PT and PTT that we all learned 100 years ago. And we're not saying that they don't have a role. They do tell us something, but they have their limitations. And one of the big ones is time, because they have to be sent off to a lab. Even if they're working fast, there's transport time, there's resulting time, and our lab partners do a great job trying to make it as fast as possible.
Right.
But the information is not enough, essentially, and it takes time. So a device like ROTEM allows us to have much more real-time information. It can be done right at the point of care, right where the patient is, versus sending it to wherever. And not all tests can be done that way, but this can. So we're able to very quickly get information about, again, how patients are forming clots or not, or how they're being dissolved, and what's missing or not missing in their system. Coagulation is a complex process.
Right.
right? And we learned it. You learned it in school, the coagulation cascade, right? It probably kept you up a few nights studying before an exam.
Yeah.
So,
Right.
but what we see in real practice many times with our surgical colleagues is that they will say, "I just know, I can look at that patient bleeding and I can see what's going on." They use instinct, and not to say our surgical colleagues don't have great instincts; they're phenomenal at what they do. But why wouldn't we want more and better information more quickly? And so a device like Rotem allows us to, again, very quickly get that information back at the point where the patient is being cared for and make a good decision. So that decision may be, let's use this blood component, or we don't have to use this blood component, which we may have actually jumped to before, right? Because that's what we thought we should do, or based on sort of our PTPTT, we think we should be doing this. But now we can actually get much more detail about what is missing or not missing from the patient. Maybe the decision is to use a different factor concentrate, which also, fortunately, we have available to us in this country. Or maybe the decision is to wait, or maybe we could have any number of decisions, but it helps us to make a much better clinical real-time decision.
Right. And there's a machine called a Rotem Sigma, I believe, which is a sort of a tabletop machine the size of a computer, and you can bring it to the patient's bedside. Is that right?
Yeah, it can be at the point of care testing the bedside. So again, sometimes our concept of looking at coagulation is this is sort of this distant information that the lab hopefully gets back to us, and then but patients are bleeding right here, right? And if you've ever been in that situation as a clinician, that is a high stress, tense moment. We want to control that. And so the closer we can get that to the bedside, so the newest technology is the Rotem Sigma. And I don't sell the device, but I certainly work with lots of clinicians who see the benefit to getting that information and making a much better decision. And as a result, some blood components may be used, but absolutely those will be used in a judicious way, not just based on an instinct or based on a habit or based on drama or excitement or stress at the moment, based on real information and evidence about what will or will not help a patient in terms of their coagulation.
Right. So it'll help you decide whether the patient really needs a transfusion right now or whether you can wait a while. And
Or there are other elements, right? We are again fortunate to be able to, science has enabled us to extract certain factors from the plasma of blood. So we're able to then say, well, this patient, they don't need us to just throw the spaghetti at the wall and see what sticks with all these blood components. They specifically need this factor, or they don't, or they need this much of it. So, with technology like this, it's much more goal. It's what we call goal-directed therapy, right? We know what we're trying to achieve. We're not just hoping for the best by using a whole mix of sort of blood components just because they're available from the blood
right,
bank doesn't mean that we're necessarily helping the patient. So this kind of technology helps us to make a much more informed decision.
right. Does the Rotem Sigma also help us with patients who are, let's say, on anticoagulants and aspirin or
Yeah.
Xarelto, Eliquis, Plavix, things like that?
Yeah. And how many of our patients are on these agents, right? You're not
Yeah,
involved
yeah.
in
Many of
this.
my patients are on various types of
Yeah. Right.
anticoagulants.
So
That's
yes, it does. It does help us to understand better how their blood is going to perform, essentially, right? Just like with other organs, we do all kinds of tests to see what is the expected performance under stress. The same could be said with use of Rotem with patients on these agents. What is happening with their actual coagulation system versus the limited traditional testing around PT-PTT and calculated INR. Again, there's a place for those tests. I'm not saying
right.
that they should go away, but wouldn't we want more deep information if we could, especially with these agents? And there's a new one on the market every day, right? There's going to be more of them every day.
Right. Same with patients with hemophilia, a genetic
Yeah,
bleeding
yeah,
disorder.
genetic
There's
bleeding
a
disorder.
new drug that was recently approved a few
Mhm.
weeks ago for that. But those patients are at high risk of bleeding.
Sure. So the
If you
more
have,
information, the better, essentially, right? Because then it enables us to have some predictive ability of what's likely to happen next in terms of the coagulation. So again, application to a wide array and surgeries like liver, right, or heart surgery, where no matter how great the surgeon is or the team is, there's going to be bleeding. That's just the nature of it. Wouldn't we want to control that as much as we can and keep that blood, again, in the patient and healthy as much as we can, optimize their own ability to coagulate or to to clot their blood as appropriate or to stop the bleeding. Again, I'm oversimplifying. It's a complex process,
Right.
but it all speaks back to the same concept of patient blood
So,
management.
how are you spreading the word about PBM, patient blood management, to doctors and nurses and clinicians? And what do you think the future of that is?
Yeah, and it's an important question. And I will say I'll start with a little bit of the downside and then the upside. I think that we're probably a little behind in the United States from many parts of the world where there are really national initiatives or national mandates. I'll name a couple of countries off the top of my head: Turkey, China, Italy, Spain, Portugal, a huge movement in Mexico, where at a governmental level, and again, government doesn't solve all our problems, but at a governmental level, there are health ministries saying you need to do something about this, right? Managing and preserving the patient's own blood is this untapped resource. And it's sort of like the fossil fuel thing, right? Like fossil fuel doesn't go away, but are we tapping into other sources? So that's what we're saying is this untapped resource of the patient's own blood. So that's a little bit of the maybe downside that because for many reasons, one of which we don't have a national hemovigilance system, we don't have national healthcare, we don't sometimes have the same data or the same ability to mandate the way some other places do. That being said, what's the upside is many hospitals certainly see the dangers, the challenges associated with blood shortages. As we started our conversation, those are not going to change. We are not dramatically increasing the donor pool. Data says that this next generation is not donating necessarily the same rates that previous generations is. So there'll be this mismatch unless we look at the supply side. Plus, there's the expense side, which we didn't even really tap into, but blood is immensely expensive for hospitals. Here in the United States, hospitals have to buy their blood from either blood providers or the American Red Cross. And again, I'm not penalizing those folks. They do a lot of work to keep this supply as safe as it can be. But many institutions are looking at also reality is the dollars are a factor, looking at cost. So if we looking at this thing we do a whole lot of the time for not a really good reason, and it's actually really expensive. And as you know, as a clinician, it's not just the cost of buying blood, transfusing a unit of blood is a labor intensive process, particularly for nurses,
Right.
right? You watch the patient, you watch for reactions, and you do vital signs. There's a whole protocol around it. That's an expensive process. Testing, transport, it's an expensive process. If
Right.
if conservatively half the time we didn't need to do it, we're only adding risk and cost if we're not adding benefit. So many hospitals in the United States, and that's the joy I have in my day job is really collaborating with institutions across the United States who are interested many times, and that's okay, in reducing the financial burden. But we also know really that the impact is improving patient outcomes. So there's that part of my day job, which is a pleasure at HC1, but also with my work with the world, our work, I shouldn't say me, it's many people with the World Health Organization and other professional societies, really, creating these implementation plans and programs. So we're not just saying to people, this is important, go do something about it. Specific, what does that look like? What does that look like in a high income country like the United States? What does that look like in a low income country where there's almost no resources, but you maybe have a few? How do you do something about patient blood management? So we are spreading the word, but the main thing is we want to get the message off of the product and onto the patient. We have this, again, immense untapped resource that is inside of each of us, right? Our own blood, and it should not be overlooked and ignored anymore in ourselves or in our patients. Keep the blood in the patient and keep it healthy. That's patient blood management. So
Right.
we think there's, to your point earlier, there's a public health aspect to it. There's a patient empowerment, even in our definition of patient blood management, which we did publish a couple of years ago in the literature. We talk about patient empowerment. Just like we want our patients to wear red in February and ask their doctor about their heart health,
Right.
right? And heart health may mean something a little different to a patient from it might mean to a cardiologist, but it means something to all of us. What does blood health mean, right? I want to take some ownership of that as a patient too.
So, should patients be asking their doctors before they get a transfusion, are you sure I need a transfusion, or can I wait a little while, or are there other alternatives to build up my blood rather than transfusing me?
Absolutely, Robert. And I think we would love to see is before we even get to that point, right? When people are having their annual physicals, we hope they go. women are going to their GYN. How is my blood health? The way somebody will say, "Hey doc, how's my heart?" Right? The doc is listening, and they want to know, well, how's my blood? How's my blood? And again, I don't want to make this all about women's health, but it's such a big factor, particularly our female
Right.
patients. Like, how am I doing? And we know in many cases we just have been sitting there looking at their anemia. Can we do something about that? Then certainly, at the point of transfusion, right, there are moments that are highly stressed, where there's hemorrhages, or that we're not necessarily talking about those moments, but that's not when most of the transfusions happen. Most happen in the scenario you described, where there's a conversation with the patient and the clinician, and we would like patients to have those conversations with their clinicians, right? Their providers, say, what are really the reasons, right? What are the symptoms? What's going on with me? Signs and symptoms that you think are going to get fixed. And if it's the answer, sadly, often is, well, we don't like the number. That's not the answer.
That's
It's
not good enough.
right. And I'm a little tired. That's not the answer either. We want to really see significant, just like with the kidney transplant, right? We wouldn't say, well, patients, their BUN creatinine just a little off. Patient's a little tired, a couple symptoms. Let's put a new kidney in. It sounds almost ridiculous, but the same with blood. Like, have we addressed all those other signs and symptoms as best we could? Right. Sometimes we'll see clinicians say, well, the patient was tachycardic, patient's heart was fast. Well, tachycardia can be from pain, post-op pain too, right? This is a very simple example. I mean, that's maybe an oversimplification, but have we looked at all of those things? And then maybe for some patients, the transfusion is indicated. We're not saying that's never going to happen, but have we ruled out those? So yes, we want patients to have those conversations. Again, not fighting with their physicians, but these are partnership decisions, right? If you're doing something that's that significant, partner with your provider and ask the right questions.
Right. Now, you mentioned something that I didn't consider, and that was the expense of a blood transfusion. Do you know approximately what it costs to get one unit of red blood cells?
I do. And actually, again, I don't know how you create links. I was very privileged to be part of 3 papers that looked at the cost of both of red cells first, then platelets and plasma. Red cells being the most common. Um, Again, in a general sense, $250 to $300 is about what it costs a hospital to buy a unit of red cells. Because right, the providers, the American Red Cross or the blood centers are diligently testing. It's a complex process to get it from the donor's arm into the recipient's arm. But we actually did and published the study. We looked at 2 sites in Europe, one here in the United States, my home hospital in Englewood, New Jersey, and one up at Brown University at Rhode Island Hospital. And we looked at the actual cost of transfusion, not just the cost of buying the product. And we found that it was 3.5 to 4 times more to transfuse that blood than it was to acquire that blood, and actually multiples more in the case of platelets and plasma. And again, we could say, Robert, that, well, we do expensive things for patients all the time. They're expensive antibiotics. Joint implants are expensive. That's okay, right? Good healthcare is expensive, but again, when you partner that with the fact that, again, conservatively half of the time, conservatively, probably more like 80%, but conservatively half the time, we didn't need to do that. It was not indicated, and we didn't even talk about avoidable. That's billions and billions and billions of dollars,
Adds
and
up.
billions of nursing hours and physician hours that we certainly could use to be doing other things. So that's a tremendous factor, is cost. And we need those healthcare dollars in other places, not used on something that was not really indicated or we could have avoided.
This has been very educational for me. I learned a lot, and I'm sure the people watching this as well, so that they understand what the process is if they need a blood transfusion, what questions they should ask, and what the issues are. So I really appreciate your taking the time to join us today to discuss this topic. It's very informative for me. Thank you.
Thank you so much. Thank you for the opportunity. It was a pleasure to be here.
Thank you.